This is Raj Mehta. Welcome to the fourth lecture on evidence-based medicine. In our previous video, we left off on critical appraisals. Specifically, we discussed and reviewed clinical trials as well as different types of study designs. Today, we're going to go over different types of error, including random error and bias, as well as discussing how to minimize and identify bias in study designs. Again, the goal of all critical appraisal is to assess the validity or truth in your study. What we're looking for here is to see if we can believe the result that we're being presented with. What is error? What are we talking about when we're discussing error? Error is just basically what it says, an error in our results, something that means that we can't take the value that we're given. Now, there are two kinds of errors you might get in any kind of experiment or study. The first is a random error. Random errors are just errors due to variability or chance. Let's take an example of a study. Let's say we want to measure the average height in the population of a city, and we design a study where we randomly select 100 people, just a flawless study design. So the first time we do this study, we select 100 people and we find out the height of the average population in that 100 is about 180 centimeters. Then we decide to do it again. We do a second time, randomly selecting 100 people from our city, and this time, for whatever reason, we end up with a few more short people, and we find out that our average height is 165 centimeters. How do you reconcile the differences in these two values? There's obviously an error or difference here. Well, this error is just due to random chance. The first time you just randomly happen to get a few more tall people, the second time a few more short people. And this is what random error is. It's something that is outside the study. It doesn't have anything to do with the study design. It's usually due to the environment or observer or some other form of chance. This is very different from systematic error. Systematic error is an error where you have a problem with the study design that leads to inaccuracies. This type of error is known as bias. And this is the main thing what we look at when we evaluate the methods section of our study. We're trying to see if there's any issues with the design that might have created bias and led to a systematic error. There are some other terms that you may have heard with this. Random error is also known as precision. It's the precision of a study, where a systematic error tells you the accuracy of a study. The less random error, the more precise your study is. The less systematic error or bias you have, the more accurate your study. Next, we're going to discuss random error. Random error is conveniently broken up into two types of error, type 1 error and type 2 error. Type 1 error is a false positive. This happens when you get a study that gives you a positive result. But in reality, the truth is that there is no difference, change, or finding. Type 2, on the other hand, is a false negative. This is when you do a study that gives you a negative result, but the reality is that there is a finding, a difference, or positive result. So I'll give a brief example of this. Let's say I want to find out if it's raining outside. My test is I'm going to go outside and see if I get wet. So if I go outside and it's raining, I get wet, that's a true positive. If however I go outside, but someone throws a bucket of water on me, I would end up wet, so I have a positive study result. But the reality is that it's not actually raining. My test was a false positive. I didn't come up with a good test. On the other hand, let's say I want to find out if it's raining, so I go outside to see if I get wet. But someone puts an umbrella over my head. Well, I get a negative result. I'm not wet. But the truth is that it is raining outside. That would be a false negative. Type 1 and type 2 error are also known as alpha and beta. Alpha is the probability of getting a type 1 error, and beta is the probability of getting a type 2 error. In population studies, our goal is to reduce alpha and beta to reduce the chance of having a random error. The way we try to reduce beta error is by increasing the power of our study. Power is calculated based on usually the size of your study and treatment effect. The larger your power, the smaller your beta or type 2 error. In most studies, you aim to have a beta of around 10% or less. Type 1 error is usually reduced by setting a percentage cutoff for a significant result. In most studies, this is set as 5% or 0.05. Once we set this cutoff, we use this for our p-values and confidence intervals. We'll discuss p-values and confidence intervals a little bit later, but by setting a type 1 error of 0.05, we're forcing our study to come up with a p-value less than 0.05, and we're getting a confidence level that that result is true. And that confidence is 95% because it's the opposite of the 5%, 1 minus it. So we have a 95% confidence that our result is true when we get a p-value. So again, random error determines the precision of our study. We want to reduce the random error and increase the precision by 1, having a good power calculation, increasing our power to make sure we have a low beta or type 2 error, and 2, setting a good alpha cutoff for type 1 errors to help determine our p-values and set confidence interval significance. Systematic error is the most commonly addressed issue in study design that needs to be evaluated. When we discuss systematic error, what we're looking for is bias in our study. There are many different forms of bias, and each one needs to be evaluated to make sure that there aren't any forms of systematic error in the study. Let's review these different forms of common biases. There's selection bias, performance bias, detection bias, attrition bias, reporting bias, and actually there are dozens of other types of biases, often which are specific to the style of study design, but these are the main ones that we're going to discuss here briefly. So selection bias refers to a difference in the baseline characteristics in the populations being compared. So this could mean, for example, that if you have a study where you're measuring height, your baseline difference in one study you pick all males and the other one you pick all females, that difference in characteristic is obviously going to create a selection bias and error in your results. Performance bias is a difference in care that is provided between your two groups. Let's say you're doing a study where you have two groups and you're trying out a new drug X. Well, the patients you know who are getting drug X, you may try to see them more often, more frequently, and ask them more questions because you know they're getting this drug. Well, you're giving them different kind of care and you're exposing them to care more often, and that's creating a performance bias between the two study groups. Detection bias just refers to the difference between how outcomes are measured between the two groups. For example, if I'm doing a study and I'm measuring height in two different groups after they take a drug X, I may know that group 2 got drug X, so I may be paying more closer attention to how I measure it and using really accurate tape measures and so forth, whereas in the other group I can do it more haphazardly because I know it's not a big deal, and that could create a difference in how I'm measuring it, or a detection bias. Attrition bias refers to a difference between how many people withdraw from different groups. If I'm studying drug X in a population, I have group 1 and group 2 get the drug, and the group 2 people who get the drug are 10 times more likely to drop out of the study, but I don't take that into account of my results, I can create an attrition bias, and it biases the results I'm getting. Finally, there's reporting bias. Reporting bias means that you're more likely to get a study reported if you have a positive result. This tends to affect meta-analysis. A meta-analysis attempts to compile 10 different studies to show their cumulative effects. There may be reporting bias. They may find 10 studies that all show positive effects, but 10 other studies that showed negative effects were never published, and that can skew the report of that meta-analysis. Or systematic review. Other biases. There are many other types of biases you can identify in this study. Due to time limitations, I haven't reviewed them all, but I'll mention several important ones that you can look up on your own if you come across them. Some of these include channeling bias, interview bias, lead time bias, length time bias, recall bias, referral bias, and much more. The global concern with any systematic error or bias is that it deviates from the truth. It creates errors in your results. The challenge with systematic bias is that this is unpredictable. Whether your bias overestimates, underestimates, creates a small deviation, or a large magnitude effect is difficult to know. Every study has a risk for bias. The goal of a good study design and methodology is to minimize that risk so you feel that there is a small or minimal amount of systematic error in that study. Study designs can be chosen to help reduce the risk of bias. To reduce selection bias, most studies will use randomization and allocation concealment. Randomization means that the people selected in your population study are chosen at random, and allocation concealment means that that randomization is ensured, unpredictable, and not visible as that process is going on. Performance bias can be reduced by blinding. This is also known as masking. Effective blinding means that different groups receive equal amount of care, treatment, and intervention because no one is sure who's in which group. It is important to note that in some studies blinding is impossible, for example, whether a patient has had a major surgery or not. Keeping that in mind is part of assessing the risk of bias and the optimal way that systematic errors can be reduced. Detection bias can also be reduced by blinding, but opposed to the blinding and performance bias, which is usually for the patients or the doctors in the study, detection bias can be reduced by blinding the people who measure outcomes. This is especially important whenever you have subjective outcome measures, like pain scores. It's really important that you have a blinded assessor to make sure there's no detection bias. Attrition bias unfortunately can't always be reduced, but it can be reported and accounted for. Most studies will have a flowchart to discuss and incorporate attrition in their study. It's also important to make sure that your study has reported complete follow-up. A study with a good follow-up and its methods can help reduce attrition bias. Reporting bias can best be overcome by data transparency. The more data you can have access to, even from negative studies, helps you ensure that you don't have a publication bias, and you can look at both the good and bad data to make a systematic or meta-analysis that is thorough and complete. We have completed reviewing critical appraisal as well as systematic and random error. In our next video, we will go into clinical expertise and going into how to apply evidence-based medicine in practice and evaluate results.